make those nominations. So without further ado, I'll ask Dr. Young to introduce Dr. Clark. Thank you.
Thanks, Oyeri. It's my pleasure to introduce Dr. Katherine Clark. By way of background, for those of you who might not know, Katherine is a graduate of Haverford College and the University of Pennsylvania Medical School, and also received an MBA at that time from the Wharton School of Business, somewhat unusual background, quite unique. She then went on to do internship and residency at Penn and came to us as a cardiology fellow 3 years ago. She's quite accomplished already, having published 3 papers and 3 editorials and co-authored 8 additional publications during her early career. She's quite active in the American College of Cardiology. And for those of you who have had the good fortune to work with her clinically, you recognize that she has outstanding clinical judgment, excitement about learning, and a clear commitment to the highest level of care for her patients. For those of you who have also had a chance to work with her in the research realm, I think you've been impressed by her intellect, her insatiable curiosity, and her commitment to scholarship. So without further ado, I want to welcome Katherine to the podium, and we look forward to your talk.
Okay. Thanks, Dr. Young, and good morning, everyone, and thanks for joining me today. I'll be speaking about value and innovation in heart failure management, providing perspectives from not only the health system level, but down to the patient level. In addition to my medical training, as Dr. Young alluded to, which was initially at Penn and now at Yale, which has all been excellent, it's really been the additional experiences that have greatly shaped my interests, and it'll provide some context for the array of projects that I'll share with you today. During college, I interned 2 summers at B. Braun Medical. During my first internship in the OEM department, I created an orientation manual for new employees, describing the process of development of a medical device. Particularly, it was a neonatal IV set. During the second summer, I worked in the Regulatory Affairs Department, creating submissions for the FDA. During medical school, I then enrolled in the MBA program, and fortunately, Penn has the largest healthcare management department in the country, ripe for opportunity. Then, as part of the MBA program, I interned at Becton Dickinson. I worked in the Strategic Innovation Department, which was a perfect fit for me, collaborating with both R&D as well as business development. My project that summer was defining, prioritizing, and assessing unmet clinical needs, and then finding companies that provided solutions to those problems, such that BD could potentially acquire them and add them to their portfolio of hospital solutions, more than merely providing and delivering vacutainers and syringes to hospitals. They would joke, BD is everywhere, but nowhere, all at the same time. Residency was obviously incredibly busy clinically, but I was able to be a member of the Penn Cardiac Valve Committee with Dr. Howie Herman, who I met when he guest taught at Wharton, and we helped to standardize TAVR care across the growing health system. Now, while at Yale, I was elected to the Wharton Healthcare Management Alumni Association Board of Directors last June, and was recently nominated to serve as vice president, now collaborating with alumni from across the globe. I've been fortunate in not only my medical training, but also these experiences, and they've taught me so much about the field of healthcare and how I help and how I hope to define how I want to make an impact in the field of heart failure one day. So as a brief outline for my talk today, first, I'll talk about the components of healthcare value. Then I'll discuss 5 of my current projects regarding how to tackle these value components from the national level down to the patient level. First, I'll discuss 2 projects that regard improving cost at the national level with innovative payment models. Then I'll talk about improving quality at the institutional level with EHR technology. I'll then continue down to the patient level and discuss improving quality with novel uses of our common advanced imaging modalities. And finally, I'll discuss improving access with national standards for clinical trial design. So first, to start off, it's important to understand the mechanics of the US healthcare system to discover the unmet needs at the national level in order not only to take care of patients, but to shape policy as well. From the national perspective, the US healthcare system is incredibly intricate and complex. There are many involved stakeholders, and each has their own incentives and constraints. It's also important to recognize it's not a one-size-fits-all model. There's significant geographic variation and needs. For example, I look at the major differences in the healthcare markets where I trained in Philadelphia with multiple large competing health systems. Now compare that to New Haven, where Yale New Haven Health is essentially the only game in town. And it's interesting to see how they expand to gain influence in the area. Despite this complexity, the unifying goals are actually quite simple. We all want to improve the quality, the cost, and the access to care. However, the challenge is that improving some aspects often comes at the expense of others. This concept is known as the legendary Iron Triangle of Healthcare, a key concept we learned in the Healthcare Management Department. So then, how do we use this knowledge to find ways to innovate within the field of heart failure? I'll now go on to describe how we can improve the various aspects of value, quality, cost, and access along the entire continuum, from the national level to the patient level. So first, understanding the national trends in outcomes, utilization, and cost allows us to find targets of low-value aspects of care to improve upon. So working with Dr. Desai and Dr. Ahmad, as well as Elliot, Sam, and Brad, among many others, we worked on numerous projects together utilizing national databases. For the first project that I'll share with you today, we sought to understand the most contemporary trends in socio-demographic profiles, outcomes, and utilization for heart failure hospitalizations. It's well known that heart failure is one of the most expensive medical conditions in the US. It was already $31 billion in 2012. However, currently, there's little known about the national trends of HFpEF versus HFrEF hospitalizations. But it is believed, and prior work has shown that these two conditions do incur different costs. So what we did is we used the Nationwide Inpatient Sample, or NIS. This is the largest publicly available US all-payer inpatient discharge database. We then looked at hospitalizations of adult patients with a primary discharge diagnosis of heart failure from the time period of 2008 to 2018. We then used ICD-9 transition to ICD-10 codes and stratified our results into HFpEF versus HFrEF. So overall, for our results, we identified 11.7 million hospitalizations for heart failure over the study period. Early on, as you can see, hospitalization volume remained fairly stable, but did increase in later years. You can also see that over time, our recognition and understanding of HFpEF, as well as even the coding, got better, with fewer primary diagnoses of unspecified heart failure, which is depicted in the light blue bars. Now, in moving on to the demographics and comorbidities, in directly comparing the demographics of HFrEF versus HFpEF hospitalizations, as I note on the left, we have found that HFrEF patients tended to be younger and primarily male. There was also higher proportions of Black and Hispanic patients in that cohort. In terms of comorbidities, HFrEF patients were more likely to have coronary artery disease, as you can see at the bottom of the table in the right. However, the remaining comorbidities were more frequently seen in HFpEF patients, and all of these were statistically significant. It's also important to realize that in the context of this time period, the Affordable Care Act, or the ACA, was enacted during March 2010, and the associated state-based Medicaid expansion programs could have well impacted the demographic profile of the patients who end up seeking care. So now I'll highlight the important trends in our hospitalization outcomes. First, over time, the patient population became more diverse over the study period across all subgroups, and heart failure overall as well. Next, importantly, we found that hospitalization costs for all heart failure admissions, as well as both subgroups, HFpEF and HFrEF, have decreased significantly over time. These decreasing costs may be partially due to improved inpatient management of heart failure exacerbations and enhanced outpatient coordination. However, we found no meaningful change in the length of stay over the study period. All was about 4 days. However, we have to consider that as the US population continues to age, the baby boomers reach Medicare age, the decreasing cost over time is in fact encouraging. But given the increasing volume of heart failure hospitalizations that we've seen, it appears unlikely that the total costs to the overall healthcare system will decrease. We also must consider changes in the reimbursement patterns over the study period, with the increasing use of bundled payments, and this may also contribute to the changes in cost over time. In addition, we found that there were increases with home health care, resulting in additional resource utilization and cost following admission, which also must be considered. Lastly, HFrEF admissions incurred higher cost compared to HFpEF, as well as in-hospital mortality. In fact, with the recent expansion of the HFrEF drugs, including ARNIs and SGLT2 inhibitors, in looking forward, we can expect and hope to see a decrease in mortality and cost among HFrEF hospitalizations. And as these therapies hopefully will be indicated soon for HFpEF, pending, of course, the results of DELIVER and EMPEROR Preserved, there might be even further acceleration of improvement in these hospitalization outcomes. So the future is exciting. So now, as we begin to understand the variation, we can then drill down to studying specific subpopulations of heart failure patients. So now I'll move to the second project that I'll discuss. Specifically, 60% of heart failure patients are actually 65 years or older, and heart failure is the most common admission diagnosis for all Medicare beneficiaries, and these hospitalizations are known to be costly, and they're in fact longer. In addition, prior studies have demonstrated there's significant variation across the US in these Medicare payments for heart failure hospitalizations. So it's a huge target. As the country transitions slowly, ever so slowly, from the fee-for-service to value-based models of care, in 2018, the Centers for Medicare and Medicaid Services, we all know as CMS, instituted the Bundled Payments for Care Improvement Advanced. This is a voluntary program in which participating hospitals assume full accountability for the total costs within a 30 or 90-day episode of care following an admission. Thus, we sought to understand contemporary Medicare payments for both 30 and 90-day episodes of care for heart failure admissions across the US. To do so, we used Medicare fee-for-service administration claims, and we identified patients with a primary diagnosis of heart failure. From the period of 2016 to 2018. We analyzed coding patterns across these groups over time. We also looked at median 30 and 90-day episode of care payments and the proportion of costs allocated to the index hospitalization and then all the care following referred to post-acute care. For our results, here we show the changes in coding over the study period, and we included the ICD-10 codes for systolic heart failure, both isolated and combined, as well as those for hypertensive heart disease, both with and without chronic kidney disease. It's interesting here to note that the codes for hypertensive heart disease increased significantly over just a short few years. We obviously have to do more work to really understand what's driving these changes. Is it a change in the patient characteristics, or in fact, are people just coding differently? And what is the impact of that on the healthcare system? Following then, in terms of the cost of these various codes, we found that 90-day episode spending was notably higher for the codes hypertensive heart disease with both heart failure and chronic kidney disease as compared to the other diagnosis. This is shown in the yellow slice in the pie chart on the left. This would suggest that the sicker patients, i.e. those with chronic kidney disease, result in higher Medicare spending. So we need to understand how the patient's severity of illness relates to additional spending. And this can then lead us to innovations and new interventions that can be implemented to mitigate this risk. Now, importantly, one of our main takeaways is shown on the pie chart in the right. When we break down the 90-day costs, it's actually post-acute care that accounts for a majority, essentially 2/3 of the spending. And the largest components of post-acute care was on readmissions and skilled nursing facilities, among many others. We also found that there's significant variation across the US of the mean 30 and 90-day spending. This was true for the overall cohort of heart failure, as well as across all the different diagnosis codes. So now what do we do with this information to refine the costs of heart failure admissions at the national level? And this is where things get exciting. What we do is we target the low value areas of care for innovation. And we know that post-acute care is costly and highly variable, as I've just shown. Previously, by just focusing on the index hospitalization, we're insulated from a significant percentage of the spending. But we can see that along the full care continuum of patient care, as the patients are discharged, is really the area that needs to be addressed. Because as I said, this is where the cost is high and it's highly variable nationally. So how do we better align the incentives between the health systems and payers to see a meaningful improvement in care? One suggestion is that we can consider incorporating 90-day bundled payments more extensively, and this increases provider accountability and risk sharing. This will ultimately require health systems to redesign patient care and focus through a value lens. We'll implement treatments and managing strategies to do so, further driving innovation. As I had noted earlier, the new heart failure therapies, including ARNIs and SGLT2 inhibitors, have been shown excitedly to be both effective clinically as well as cost-effective, an ideal medicine. For example, there was a recent article in JAMA Cardiology by Berg et al., and their team showed that the SGLT2 inhibitor Farxiga was associated with a rapid reduction in the risk of cardiovascular death or worsening heart failure. And this impact was seen in a mere 28 days, pretty incredible, and obviously well within our 90-day episode of care. So despite these new medications' increased upfront cost, utilization of these medicines will likely decrease future healthcare utilization through improving patient outcomes and ultimately driving down costs. Thus, such therapies represent a potential strategy to implement during the index hospitalization to not only dramatically improve patient outcomes, but also to improve the value of care following discharge. Really a win-win situation. As we began to see with the previous project, value matters at the institutional level. I just finished addressing cost of healthcare. Now I'll move on to quality. I'll now describe the use of existing technology within our EHR to increase the use of GDMT in heart failure. So Dr. Ahmad is leading the PROMPT heart failure studies. This stands for the Pragmatic Trial of Messaging to Providers about the Treatment of Heart Failure. And I'm sure many of you are aware of this study, perhaps already included. The primary hypothesis is that the use of EHR alerts for indicated GDMT in HFrEF will lead to increased use and prescriptions. Currently, there are two parallel pragmatic clinical trials running, both on the outpatient side and the inpatient side. So far, in only 3 months, we've already enrolled over 550 patients in the Yale New Haven Health System on the outpatient side, and it's yielding great results so far. In moving down to specifically mineralocorticoid antagonists, or I'll refer to them as MRAs, their use has been quite poor across our health system. We can see in the chart on the left, this is data from our health system in 2018. It shows a snapshot in time of over 4,000 patients in the heart failure registry. We can see that less than 30% of HFrEF patients who are indicated to have an MRA were actually prescribed one. And then moving in the graph on the left, on the right, those patients who were indicated but did not have an MRA were followed over the course of the year. And although we can see some improvement, after a year, only 17% of patients are on an MRA. And these findings are representative of national cohorts such as the CHAMP Heart Failure Registry. So as we can see, the underuse of MRAs is not at all unique to Yale, despite the robust literature we have for decades. And this underuse often stems from the perceived risks of hyperkalemia, especially in heart failure patients with multiple comorbidities and often chronic kidney disease. To combat hyperkalemia, The current potassium binders really have numerous limitations and are quite ineffective for use. Recently, however, there have been 2 newly approved potassium binders to treat chronic hyperkalemia. There's SZZ and patiromer, and they're safe, efficacious, and better tolerated. And here I list multiple randomized clinical trials that demonstrate their effectiveness. So as you can see, there's a lot of research going on in this area. In particular, the DIAMOND trial, which is patiromer for the management of hyperkalemia in subjects receiving RAS inhibition medications for the treatment of heart failure. It's currently enrolling. It's a multinational, double-blind, placebo-controlled randomized clinical trial. And as I said, it's studying the use of patiromer in patients who are already on RAS inhibition agents in order to allow them to continue these medications. And thus, the primary outcome is cardiovascular death and hospitalization. So now moving into our study, the third study that I'll discuss this morning, it's modeled after prompt heart failure. We're also using a best practice alert system, or BPA, in our EHR to see if prompting a provider to consider the use of MRA in a HFrEF patient will improve their overall use for patients in the healthcare system. In addition, if the patient has hyperkalemia, this alert will provide information regarding the new FDA-approved and available potassium binders, especially if they're a barrier for the MRA use. So in brief, this is a pragmatic, cluster randomized, open label interventional trial. We will enroll 50 outpatient cardiology and internal medicine providers. The providers in the alert or intervention group will receive an informational alert for their eligible adult outpatients. Those in the control group will not receive any alerts, and they'll continue to care for their patients as usual. To define the eligible outpatients, this includes adult outpatients with HFrEF and an ejection fraction less than 40% who are not already currently prescribed an MRA. They will be automatically enrolled and will be placed into the alert or usual care group based on the randomization of their provider at the time of their first clinic visit. And those patients that are already in prompt heart failure will not be included in this study. Our primary outcome that we'll measure will be the percentage of patients with an active MRA prescription 6 months after randomization. Secondary endpoints will be stratified by study arm, intervention, and control, and mainly will include things like time to the first MRA prescription, the number of outpatients experiencing hyperkalemia, the frequency of potassium monitoring, the use of the various new potassium binders, and then utilization, number of ED visits, heart failure hospitalizations, all-cause mortality, and of course, the total healthcare costs. Briefly, in terms of the BPA system logic, it will first find an eligible patient. If the potassium is less than 5, alert 1 will trigger, prompting consideration of an MRA. If the MRA is started, it's a success for the patient and the health system. If they do not choose to start an MRA, we'll get information why, and then it can alert again at the next visit. However, if the potassium is greater than or equal to 5, alert 2 will trigger, prompting the provider to treat the hyperkalemia, and it will provide options, as I mentioned, about the new potassium binders. And then once the potassium is treated and less than 5, the patient is again eligible and can receive Alert 1. So here's a current screenshot of the alert that's a work in progress with the team. And stay tuned. The alert is planned to go live this summer, so please keep your eyes out and contribute to the study if you get chosen. So now, moving along the continuum, down to the level of the individual patient. My next question that I'll be discussing is how can we use our advanced imaging modalities, so strong at Yale, in novel ways to improve the quality of heart failure care for the patient. With Drs. Young and Baldessari, we evaluated the use of cardiac MR in HHT patients with a very complex condition of high output heart failure. Now you'll ask about my interest in HHT. It actually dates back way to my medical school days. First starting when I interned in the interventional radiology department at Penn. And it started off from a case series of young adult HHT patients that were seen at Penn that had MIs, presumably and incredibly, through paradoxical emboli through large pulmonary AVMs that were untreated, and virtually no cardiac risk factors. So then when I came to Yale in the fall, I was in the CCU with Dr. Young, and we discussed our interest in HHT patients. So now I'm continuing to work with him on several projects of HHT patients with Dr. Young. Now I'm going back to our study, the fourth study that I'll be discussing today. We know that high output heart failure results from shunting in the liver, and it's exacerbated by anemia and chronic bleeding. And it only occurs in about 5% of HHT patients. So it's in fact pretty rare. But since we are a center of excellence, we do see a good number. In terms of the cardiac physiology, the right ventricle is subject to increased pressure and volume, while the left ventricle often maintains normal function in the setting of low SVR. So to learn more, we conducted a retrospective review of patients referred for CMR from the Yale HHT Center of Excellence from 2015 to 2021. And we assessed structural and functional parameters on CMR. More than echocardiography affords, CMR provides a comprehensive and obviously non-invasive approach to the evaluation, particularly of the right ventricle of high output heart failure in patients with HHT. So overall, we included 10 patients, almost entirely female, as you can see, with a mean age of 59 years. Regarding the CMR parameters, as you can see on the table in the right, we found that the mean left and right ventricular ejection fractions were within the normal range, but the end diastolic volume index was increased, and more for the right ventricle than the left ventricle. Not surprisingly, the cardiac output and index were both elevated as well. And we did find that late gadolinium enhancement was pretty uncommon in the cohort. And of note, cardiac index is correlated to a majority of the other parameters. More importantly, what do we make of this? This assessment can be instrumental in determining the need for and response to therapies, such as Avastin and liver transplantation. Here, we show an example of a 69-year-old female with known HHT and high output heart failure. She presented to Dr. Young with increased dyspnea, so imaging was obtained, and that's shown on the panels on the left. This demonstrates elevated cardiac index as well as end diastolic volumes on CMR. Also, the RVSP was elevated on echo compared to her prior studies. Thus, the decision was made to treat with a standard 6-dose course of Avastin, and then follow-up imaging was obtained, which is shown in the panels on the right. You can see that the cardiac index improved, as well as the volumes. These findings also correlated to her echo, with improvement in the RVSP. However, the moderate TR did stay stable. But notably, her symptoms also significantly improved. So now, taking a step back, I'll focus on the third leg of the iron triangle, access to care. We all know that it's important to improve access to clinical care to all types of patients. But access actually begins at the level of data generation from clinical trials. What we really need is equal access to obtain valid results to apply to all populations within cardiology care. To this end, I'll now share my work with Dr. Lansky and the Take Her Health to Heart Coalition. The group's goal is to promote equitable female enrollment and retention in cardiac device clinical trials. It's been a fabulous opportunity. It's a national organization that's particularly unique because not only does it include academic cardiologists, multiple national societies, and patient advocacy groups, but it also includes numerous industry partners and AdvaMed, the medical device trade organization, leading the charge, in addition to the FDA. Now moving forward, I'll describe the current disparities, reason for female barriers, and suggested changes to improve female enrollment and retention. This material that I will be showing you that I've created with the coalition has been incorporated into clinical site training for various device companies already, including Edwards, Abbott, and AdvaMed, all of our partners. To start, based on some Boston Scientific data, the lack of awareness is staggering. Only a minority of providers, from primary care doctors, even cardiologists, are well aware that heart disease is in fact a greater cause of death in women than it is in men. And the 17% of cardiologists is shocking on this slide. In evaluating clinical trials in a recent study, looking over the past decade, female participation lags across all subgroups by disease type, by age, and by region. Other studies show that there's been no significant over time of the same time period. That leads us to understanding the barriers to enrollment. There are both physician and patient factors that hinder female participation. To highlight a few examples at a high level, I will now discuss. Female patients aren't often asked to participate, and they're in fact asked less often than men. This is because they're unaware or their providers are unaware of current clinical trials. Often the risks and potential benefits are misunderstood. They think they're guinea pigs. And even when female patients are interested, they may not enroll due to numerous factors, including they don't meet criteria, they have too many comorbidities, because women patients are often older for cardiovascular disease. Or maybe later they drop out and aren't retained due to logistical, caregiver, or even transportation issues. Next, it's important to note that women have unique barriers to enrollment, such that they're more likely to have trust concerns. There tends to be more fear of experimentation and convenience and transportation issues, as I noted on the previous slide. Women tend to also make decisions differently than men by needing more time and more information to come to a conclusion. They more often incorporate the advice of friends and family, and they tend to be more influenced by altruistic considerations. Lastly, we can't ignore the sex differences in risk tolerance and its biology. Women are known to take fewer risks and even perceive a greater risk of harm from trial participation. In now diving into provider factors, I list several here that I'll walk through now. Women tend to be misdiagnosed as they are more likely to present with atypical symptoms. And providers are unfamiliar or even unaware of the current trials that are enrolling. There can also be subjective biases when approaching certain patients whom they feel are unlikely to comply, and the associated administrative logistics just seems to be too burdensome in such patients. There's also the fear of losing patients to the academic site primary investigators. And something we're all often guilty of is using too much jargon. Another important aspect is the lack of female leadership in cardiology trials and academia. The stats here are staggering as well. Women only comprise 21% of general cardiology fellows. We're lucky at Yale, it's a little higher. 13% of practicing cardiologists, and only 4% of interventional cardiologists. The figures on the right show this huge disparity as well. On the top, the percentage of female interventional cardiology across the states is in the mere single digits. And the bottom graph depicts the low number and minimal improvement in the number of interventionalists in the field. So why does this matter? This is because empowering female cardiologists is a virtuous cycle. In a recent study by the great Dr. Marielle Jessup, she conducted a retrospective review of recent major heart failure trials and demonstrated that there's been no significant improvement in female authorship of these trials in the past 15 years. There's only a median of 11% female authors in heart failure trials. More importantly, and fascinatingly, they found that female authorship of heart failure trials was an independent predictor of female enrollment. They found that heart failure trials with a first or senior author had a significantly higher percentage of enrolled females, 39 versus 26%. So really, the better science, the more women cardiologists leading trials. To overcome these barriers that I've now described, it's clear we need a multifaceted strategy to be incorporated. This includes promoting awareness of cardiac disease in women and trial participation opportunities. It's improving education and reducing all the misconceptions. And also starting from scratch and creating more focused trial design. As I just noted, the design of clinical trials needs to be changed to simplify the trial burden for women. And some of this, I think, has been highlighted in the COVID area and can help us with new strategies as well. Some potential ideas include fewer required follow-up visits, phone or telehealth visits, home visits, weekend hours for follow-up, allowing the primary care in the field to complete follow-up, and requesting transportation reimbursement from the trial sponsor. These considerations will ideally increase the number of women who qualify and can comply with the trial requirements. Another aspect of clinical trial design is the incorporation of recommendations from FDA guidance documents. As my fifth and final project that I'll discuss today, we've partnered with the FDA to better understand the awareness of providers of these FDA guidance documents, as well as their impact in the field, ultimately creating a call to action for the entire field of cardiology. As some brief background, the FDA issued a sex-specific guidance document in 2014. When you speak with the FDA representatives, they stress that these guidance documents and their recommendations are non-binding, but in fact, it's the most agile way for the FDA to inform the public of their current thinking. The document encourages the incorporation of sex-specific considerations from study design all the way to reporting results. More specifically, the guidance recommends 1, the use of sex and associated covariates during study design, 2, gender-based enrollment percentages, 3, sex-specific statistical analysis, and lastly, their expectation for sex-specific reporting. Thus, following the recommendations from this document is helpful for sponsors, medical device companies, to get their approval most efficiently from the FDA. Regarding our methods for the project, we're evaluating all completed clinical trials of medical devices, all sponsored by industry, and all publicly available information from clinicaltrials.gov. And we're examining the time period 2010 to 2021. We're comparing female enrollment and sex-specific statistical analysis, both before and after this guidance document was incorporated into completed studies, which we define as 2017. For some very preliminary results, I wanted to first highlight the heart failure-related devices. Here, we include LVAD studies on the left and CRT studies on the right. You can see the results vary from one type of device to another. And of note, shockingly, none of these trials in either LVADs or CRT actually reported sex-related statistical analysis for outcomes. Here are some additional device types that we're also looking at, including pacemakers, ICDs, and heart valves. And we're also going to include data on coronary stent trials. Overall, we do see some minimal improvement, but as you can see, there's still plenty of work to improve the incorporation of these FDA recommendations. And looking ahead, some of our future work of the coalition includes increasing social media presence, creating CardioSmart patient infographics and decision-making tools, creating an industry standard for enrollment materials, really that device companies can plug and play. We also want to increase the education in cardiovascular fellowship programs and continue to produce peer-reviewed research. So in summary, I once again go back to the iron triangle of healthcare. First, I discussed cost at the national level through novel payment models. I described 2 projects, including trends from heart failure admissions, both HFpEF and HFrEF. And then secondly, 30 and 90-day episodes of care spending for all Medicare beneficiaries. Next, I moved to the second leg of the triangle, improving quality at the institutional level with EHR technology. And I described our best practice alert for increased MRA use at Yale New Haven Health System. Then I talked about improving quality at the patient level with novel uses of advanced imaging. And I described the use of CMR for the treatment of high output heart failure HHT patients. Lastly, I described improving access at the national level, describing our work in the Take Her Health to Heart Coalition to ultimately create national standards for improved female enrollment in medical device clinical trials within cardiology. So with that, I'll conclude and thank my mentors and many collaborators for all the projects I've discussed today. And lastly, given the time of year, I'll leave you here with some summer reading. This book was just published by Dr. Robert Burns, one of my favorite Wharton healthcare professors. It's the first textbook actually in the entire field that describes comprehensively the US healthcare system. And it's based on his decades of teaching one of our foundational courses. It's a fabulous book for those who would like to better understand the complexity of the US healthcare system, and I highly recommend it. And as a part of the content we provide with the Wharton Healthcare Management Alumni Association, we have and host a series of virtual fireside chats with leaders in the healthcare field. Last month in May, I was fortunate to host him in discussing his new book. It was a fabulous conversation, making you feel like you were right back in the classroom with him, and realized how much more we all have to learn, and really why medicine is such an exciting field to practice. So once again, thank you all for your time this morning, and now I'll take any questions that you may have.
Katherine, that was an excellent talk. We have, I think, 7 minutes for questions. I can actually moderate if that's fine with you. So first one we have is from Dr. Seltzer. There's significant data showing underdosing of GDMT medication. For HFrEF, a low-cost EMR pop-up could help direct providers to optimize dosing of beta blockers, ASIs, ARBs, ARNIs, without the cost of adding additional medications. I think I'll let that up for you.
Yeah, I think that's something we can definitely incorporate into the choices of our EHR alert. That can only definitely help, because we all know it is a problem today in the field. So definitely room for something we can include.
I can add a question to this. So Katherine, I think what's been your experience with leveraging your background in bringing together research, advocacy, and thinking them through them together? So do you see a future where you could do some advocacy-based research work in the heart failure space? And are there other avenues specifically that you think that kind of tie into the diverse set of great contributions you've made in the past couple of years?
I think primarily it involves being creative and really having the ability and the network to collaborate not only with cardiologists, but people from all different departments within medicine, as well as in industry. And I think what I learned, one of the main things I learned at Wharton was my classmates I learned just as much from as I did my professors. And really it's how to solve and think about problems in healthcare from different perspectives. And it's really collaborating with these other individuals who are so educated themselves to really think creatively and find novel solutions that maybe isn't just academic research, but is similar to the work we've been doing with the Take Her Health to Heart collaboration. I meet bi-weekly with people from Edwards and Abbott. We're working with the FDA, and I think it's that unified approach and multidisciplinary approaches specifically that I've gathered from my training that can really make an impact. And I hope to continue to dive into further in my career.
That's awesome. Dr. Zarek had his hand up.
Yes, thank you for a superb talk and a Herculean effort, which is really wonderful to hear. A very brief question in terms of, I think it's your second study looking at costs. You must have drilled down as to the role of renal care in leading to the outpatient costs in the heart failure population. Do you have data on that?
We didn't yet. We solely just focused on the ICD code itself. So it's definitely something we can do in future work, because it is, as you could see, a big area of spending and understanding what drivers specifically are those patients. But we didn't in this study drill further down at this point.
Thank you.
Eric has his hands up, and then we have 3 questions, and I'm going to summarize those 3 at the end. Eric, I'll let you kind of go.
Yeah, wonderful talk, and very proud of the work you're doing and how you're pursuing it. I have a question related to the reality that our economics are always changing, and so the value propositions are also in flux. And so the question to you, as you think about embarking on a career in this field, how do you what frameworks are out there, and what have you thought through how you would prioritize those value-based questions for further evaluation? Because there's only so much time, so we want to make the biggest impact. And so I guess that's the question: is with the flux in the economics and everyone driving towards the latest rules, how do you prioritize the work that you feel is going to have the greatest impact?
Yeah, there's lots to do and lots of exciting things. I think as a starting point, I think we can all agree that in heart failure, what's recently been exciting is all these new medications are armamentarium, and really focusing on, we know that the outcomes are there, and we can see the studies so far show that the outcomes and then the cost is there too, the lower cost. So really starting simply with getting patients on these medications and letting the meds drive themselves, and we can do better, even starting with projects like Prompt HF and Prompt MRA, and really just prompting people to get these medications in use. I think simple things like that, started at an institutional level with all data we can all dig our teeth into and agree is high value and highly efficacious, then we can go bigger nationally, getting these out as well. And then concurrently, I think is what I said, it's really collaborating at a high level with multidisciplinary people in healthcare, really thinking in different ways from the private sector, even in the public sector, how can we be most agile and who's thinking most creatively to drive these innovations home. Again, realizing that importantly that in healthcare, it's in the US, it's not a one size fits all model, that really unique geographies have to determine what's most efficacious for their market. So big questions to chew on, and I hope to work on it for the rest of my career.
Oh, we have a few more questions, and I think we are kind of running out of time, so I might actually defer some of them to offline. But I think, if there's a last question by Erica, who mentions something about the sex differences in HFpEF, and if that is the reason that we have a difference in evidence base in that space.
I think most definitely. We've all seen that the percentage of females in trials is disgustingly low. So I can say that's only part of the issue, and more we can understand in HFpEF, which we all know we have to learn more.
Okay. And I will let you kind of connect with Al online. He has some great thoughts about collagen turnover biomarkers and MRA use, and several other points as well. Okay. Thank you, everyone.
Thank you, everybody.
Brilliant, brilliant.